Good morning. I'm Dr. Andrews, Professor of Medicine, Concerned Neurologist. Trachea and epispit are two important findings that we should examine during respiratory system evaluation. Tracheal shift is observed by the trail sign. Trail sign is the prominence of sternocleidomastoid on the side to which trachea is shifted. It is usually the clavicular head that is more prominent. So today I'll be discussing few questions on tracheal shift and how to interpret this. If trachea is shifted towards the side of dullness, what are the possible diagnoses? First is collapse or fibrosis. The lung shrinks and pulls the trachea towards itself. This one concept you should remember. So here you can see the trachea has been shifted towards the left side and there is the percussion nodes are impaired. So if it has a pleural effusion, it should have pushed the trachea to the and mediastinum to the opposite side. So dullness and trachea to the same side, the diagnosis is collapse or fibrosis. How to differentiate fibrosis and collapse? Collapse is usually acute, so there will not be much bony changes. If structural changes are there, crowding of ribs, drooping of shoulder, then it's more likely to be fibrosis, and history may also be helpful. This point is clear. So here is another case where here you can see there is dullness is there. There is a dullness plus trachea is shifted towards the same side. The possibilities are here you can see the mediastinum is also shifted. So that is why in respiratory system it is essential to examine the trachea and mediastinum. If the trachea and the epispit is shifted, it is a mediastinal shift. If it is the trachea is central and the epispit is shifted, that means it is only a problem with the heart. So that is the one thing you should keep in mind. Sometimes when there is extensive fibrosis or mediastinal fibrosis there, when there is in addition there is pleural effusion, you can have tracheal shift to same side. So here patient has got a fibrosis that is producing, and in addition there is a significant pleural effusion is also there. So pleural effusion and there is an underlying fibrosis. The mediastinum may not shift towards the opposite side. Hope this point is clear. Now you go to the next question. Trachea shifted away from the side of dullness. Diagnosis pleural effusion, tension pneumothorax, or a large mass. Massive pressure or fluid pushes the trachea away. So this already we have discussed. That is the trachea is shifted or pushed by fluid or air. Trachea is filled by fibrosis or collapse. So how to differentiate? There is dullness and trachea shifted, it is either a pleural effusion or a mass lesion. If it is hyperresonance and trachea is shifted, it is pneumothorax. Hope this point is clear to you. So here you can see there is a trachea is shifted, the mediastinum is shifted, there is dullness. So this is a pleural effusion. So dullness with shifted trachea to the opposite side, it is pleural effusion. If it is hyperresonance, it is pneumothorax. Now we go to the next question. What is Hoover's sign? Here you can see inward movement of the lower ribs on inspiration. Here it is clearly seen the inward movement of the lower intercostal spaces. This is seen in COPD when there is the negative intrathoracic pressure increases. The indrawing occurs. Next is, what's the difference between wheeze and stride? So wheezes are usually polyphonic because it is produced due to bronchospasm, that is a mucosal edema, or some amount of obstruction in the airways. So these different airways of different diameters are affected, so the sound is polyphonic and is predominantly expiratory, whereas stridor is predominantly an inspiratory sound, and it is due to obstruction to large airways like trachea and larynx. So that is a major difference. Remember, the stridor is monophonic, inspiratory predominantly. It is due to upper airway obstruction, laryngeal or tracheal obstruction. Whereas wheezing is polyphonic, predominantly expiratory. It is a lower airway, narrowing as in asthma, COPD, bronchitis, etc. So stridor is a medical emergency. So here you can see the various breath sounds. So when you are auscultating, you will be looking at the vesicular breath sound. So this is how you represent the vesicular breath sound. Inspiration is longer than expiration. There is no gap between inspiration and expiration. So that is classically the vesicular breath sound. Whereas in bronchial breath sound, there is a definite gasp. The expiratory sound is equal or longer than the inspiratory sound and is a fairly intense sound. In bronchovesicular sound, there is some features of vesicular and bronchial, but there is no gap between inspiration and expiration. The expiratory sound is prolonged. It is sometimes called asthmatic breathing. The advantageous sounds we will discuss in the following sessions.